Welcome back. Today we're going to continue our way through the gastrointestinal tract, this time beginning at the pylorus, which is the guardian of the stomach, and work our way distally toward the far end through the small intestine, colon, and finally end up at the anus. And we'll look at both the gross and microscopic structure. Now, having done some physiology already, you will realize that what we're doing is we're leaving the mechanical and digestive processes that begin in the stomach and moving on to where we have a major absorption mechanism going on in the small intestine. Also more digestion, and then finally as we move into the colon, we lose all the digestion of small molecules and are left only with the concentration of what's left of that bolus by removing the water. The small bowel, which is what we'll look at first, is also called the small intestine. It's called the small bowel. It's also called the gut. And its primary job at this point is continue some mechanical digestion, crushing, grinding, and compartmentalizing, and then also to continue the digestion process with enzymes and other chemicals that break these particles of food and nutrients down into absorbable molecules, and then move it along in a timely fashion through the small intestine into the colon, at which point almost everything absorbable should have been absorbed. The dimensions are kind of interesting. Let's look at the first slide. And this is a review of almost the whole gastrointestinal tract, starting with the stomach. There's the pylorus, which marks the beginning of the duodenum. And then just at the first portion of the duodenum, the dotted lines are showing you that this is an extraperitoneal or retroperitoneal organ, which comes out here at what you'll learn soon is the ligament of Treitz, and then moves on into the first half of the small intestine called the jejunum. Jejunum actually means empty because food and gas passes through here so quickly that when the early anatomists dissected cadavers, they most often found it completely empty. Now, as you recall, duodenum means 12 because this was 12 fingers' breadths long when the early anatomists measured it. And you're going to hear conflicting measurements about the length of everything else. We always talk about the small intestine or the gut as being about 28 feet long. Somebody else is going to say 32. Somebody else is going to say 24. The answer is it depends who's measuring it and when. At surgery, if you pick it up and run it through your fingers, it tends to be in a little spasm, so measurements might be shorter. In an embalmed cadaver, if we measure it, it'll depend whether we measure it in the body, all coiled up, even though we're following those turns, or cut away the vessels, which allows us to stretch it way out. And it depends on the time the patient died and so on. So these are just estimates. They're not really important. The bottom line is it's very long. It's a lot longer than you are. It's somewhere between 24 and 32 feet. And that's, again, just so you can get absorption. Now, it runs from the duodenum, as I said, and it's retroperitoneal as an organ, and then it comes out at a place called the ligament of Treitz. And the ligament of Treitz is merely where it pierces into the peritoneal cavity. So instead of being behind the parietal peritoneum, that ligament is just a fold where it all comes up and becomes visceral peritoneum again on the jejunum. So the jejunum and the rest of the small intestine is a wholly intraperitoneal organ. Whatever happens to it, perforation, infection, and so on, it's going to happen inside the peritoneal cavity. The second division, as I said, is the jejunum. It's about half the length, not quite as arbitrarily divided as it sounds. The third portion is called the ileum, and it takes up the second half of the small bowel. So we have duodenum as the first part, the jejunum, the second half of what's intraperitoneal, and the third half is the ileum, which means twisted, because it's very, very coiled. So it runs from mid-bowel to what's called the ileocecal valve right here, where it enters into the colon. It has a little bit of a valve there. It has a redundant area of flesh that in many people prevent reflux of feces going back. So when the colon squeezes to move its bolus along here, we would like none of it to go back into the ileum. This valve is incompetent in a significant number of patients. It's not physiologically significant. The only time it matters is when it matters to surgeons. If we have an obstruction, let's say right here in the colon, pressure is going to back up. If that pressure goes through an incompetent valve, it can back up all the way back through this 28 feet, back through that pylorus, and be vomited, which is good in a way. It's unpleasant, but it can decompress the situation. Patients who have a competent ileocecal valve have no place for it to go, and that cecum can get bigger and bigger and bigger and can actually explode, which is a surgical disaster. Very, very deadly event. And we actually have measurements, and we don't allow that cecum to get beyond a certain measurement before we surgically intervene. In our attempt sometimes to allow this to go away, we watch this very, very carefully. Now, this organ, the small bowel, has something in it called plica circularis. The plica circularis are circular folds. That's what that means. A plica is a fold, plicae is plural. And they're very, very prominent from the duodenum to the mid-ileum, all the way down about 3/4 of the way through the small bowel. And the way they function is when they squeeze, because they're circular and spiral, they tend to corkscrew the bolus on the way down. So it adds to its efficiency. It makes the mixing better. It also makes segmentation better. Let's look now at the blood supply, because this becomes very relevant to us as well. This shows the colon lifted up. Transverse colon is lifted up and away. And here's the pylorus and a representation of the small bowel, jejunum, and ileum. If you remember, we looked at the first vessels that came off the aorta that supplied the liver and stomach. The next vessel down is called the superior mesenteric artery. Mesentery refers to the folds of tissue that hold the vessel and go to the intestine. Those are mesentery, and they are intraperitoneal, and they're covered heavily with fat and visceral peritoneum. So you would not normally see the vessels very well unless the patient were very, very thin. The vessels of the duodenum you've already seen. The ones that go down below here are jejunal vessels, and look how they are very long and straight. Compare them with a much longer loop and much shorter vessels, supplying the bottom half of the ileum. That's how we tell where we are in the operating room. We have this big coil of guts, and sometimes you can't tell where they are because they slide around and you can be picking up one portion and it's not where you think you are. So if we want to know whether we're in the jejunum or the ileum or which way to go, what we do is we do hold this up to the light and try to see the length of these vessels. The jejunal vessels go all the way out before they branch, and then they branch into these little arcades and supply the wall of the jejunum. The ileal branches take one long loop out and then have very short branches here. Notice something very interesting. We have this superior mesenteric artery. It makes a big loop here and starts supplying the right and part of the transverse colon with lots of arcades and, as you now know, anastomoses for backup. Look at the small bowel. It has arcades too. They're just in a different position, but they'll do the job just as well. They really are excellent at doing that. Now, we're going to get to the colon later, but I want to show you right now for a moment that on the colon side of things, here's the superior mesenteric artery cut and the small bowel removed so you can see the inferior mesenteric artery. And it has arcades and loops, which I'm going to talk to you about a little bit later. But look where it goes. It's going to go back, and then when it gets where it's going to make an anastomosis up here with the ileal branches. So we have two major vessels, the superior and inferior mesenteric vessels, both feeding each other in an anastomotic form. This is great backup because the gut is a vital organ. So when we go down here, we have other vessels. These are called the jejunal vessels. These are called the ileal. And then we have some ascending vessels and an appendiceal vessel to give blood supply to the appendix, and a very, very redundant backup system. There's something else here that's of interest. Look at the way the superior, known to its friends as the SMA, superior mesenteric artery, comes underneath the pancreas and then crosses over the middle of the third and fourth portion of the duodenum. Picture somebody having a huge meal and filling these loops filled with heavy, heavy food and standing up. It would tend to pull this down and might compress the duodenum and maybe obstruct it. There's a rare but well-described disease called superior mesenteric artery syndrome. There are a group of people, you run across one every 5 or 10 years in a big practice, so it's quite rare. Right after their meal, they start getting symptoms of obstruction. They get bloated, nauseated, they may start vomiting, and they tell you that when they lean way over or get on their knees and hands, that it goes away, because as you can see, it would tend to swing the vessel away and relieve the obstruction. Very typical story. One of the treatments for this has been to cut this vessel in half, lift up the duodenum, get behind it, and sew it back together again behind it so that doesn't happen. What's more significant is that it hardly ever happens, even with this situation sitting here. It's still very well designed. That's the gross anatomy of the small intestine, its blood supply. Very, very simple, just the naming that you'll get used to. We'll look now at the microstructure, which is actually a bit more detailed, and it's really just a variation of what we've seen already in the stomach and the duodenum. If we look at this slide, you should be very familiar with this. It looks a lot like what we've seen already. Let's go from the outside. Here's the serosa, present everywhere, but as you recall, the esophagus, and I'll show you later, the rectum. That's that visceral peritoneum. Here you have some longitudinal layers of muscles on the outside, just like the esophagus and the rest of the bowel. They don't exchange positions. And then we have the circular layers here, which do the squeezing while the longitudinal layers do the pulling up. Look in here at something called the myenteric plexus of Auerbach. Right in here are nerve bundles that run along, signaling each other to coordinate the peristalsis, or the squeezing motions. Then we go up here and we have both blood supply and lymphatic supply in the submucosa, because it's beneath this mucosal layer. And here we have a very typical slice of the mucosal layer as it sits in its villi. It's designed to have maximal absorptive power. This is where all that stuff that we have tried to chew up and digest and chemically break down are going to get absorbed. The villus, or villi plural, is a tuft named after a tuft of hair, and they're finger-like projections into the mucosa. A single villus is what we call the functional unit for absorption. And if we look at the surface, there's about 40 of these guys, this villus, per square millimeter. And that's very, very tiny. Each villus contains its own artery, bringing blood in, which will be oxygenated. It has its own vein coming back out to that intestinal system of veins. And it has something called a lacteal, which is a side branch of the lymphatics. I didn't get into the lymphatics in our vascular lectures, but you should know that the lymphatics is a whole separate circulation system. It exchanges fluids between the cells. The blood supply has this exchange with the cells, but we get something called interstitial fluid. And there's a whole chemistry to that. And it's just the fluid milieu that lives between the cells. And it has different compositions in different places and in different physiologic situations. Those lymphatics drain into bigger and bigger vessels, just like the veins do. The lymphatics then coalesce in the abdomen, and they make their way up through the chest, on the back wall of the chest, and up into the neck, where they dump into the biggest veins that are heading toward the heart. So that circulation also is returned back to the venous side. Now, these lacteals serve a purpose. They can absorb fat, and they can get big particles of fat that may not be able to get into the smaller circulation of the veins and carry them back into the circulation. And in fact, if you operate on someone who's just eaten, for example, after a car accident, and you lift up that area of jejunum to hold it up to the light, let's say, and look for the vessels, what you'll see is thin white lines, absolutely white opaque lines, and those are the lacteals that are filled with fat. And it's the fat that gives its opalescence, just the same way you would see that in milk, the way milk gets cloudy from mostly the fat that's in it. Now each villus is broken down into something called a microvillus. And I want you to look at that. This is the structure of one of those guys that you just looked at. Now these microvilli have a brush border, just like the other hair cells we've seen. If you look up here, here's the solitary villus. Here's a cell of a microabsorptive cell, and it has microvilli. This has 200 million microvilli per square millimeter. So I can't make my fingers tight enough to give you 1 square millimeter. It would just let light through. There's 200 million of these brushes here. And so just the way this border increases absorption over what we would have up here, these multiply it again by a factor of millions. And we have these in here with a totally different function than they had on the respiratory cells, where they were used to remove foreign material. The hair cells, which are just like these, had another function. They were to detect movement. So the respiratory cells actually actively beat up toward the mouth to get rid of foreign particles. These cells are different in that they are there to increase absorption. Also, there are glands located down here. If you look at right in this area, these are called the crypts of Lieberkühn. Down in the bottom, you have little pits down here, and they have other cells within them because these cells are going to secrete a lot of intestinal juices. The ones up here are doing the absorption. The absorptive cells here with the microvilli are for bringing in the molecules of nutrients. Cells down here, for example, this enteroendocrine cell secretes secretin, cholecystokinin, and gastric inhibitory peptide, which we've already looked at. And you have these cells allowing their secretions to get out, or they can also get into the circulation, where they can go on and signal other areas. There are Brunner's glands deep in the deepest half of the duodenal mucosa, and they secrete an alkaline mucus. The Brunner's glands are a little different in the other mucus-secreting cells because they're there to neutralize the acid. So they tend to be higher up in the GI tract. Then down here we have goblet cells, named because of this funny configuration. And what you're seeing here are little droplets of mucus. And the mucus is a glycoprotein, a sugar protein, which is there to protect any of the digestive tract from digestion itself. The microstructure contains other areas called Peyer's patches, which is not shown in these slides, and it's a name you haven't come across yet. Peyer's patches are patches of lymphatic tissue. We're going to talk more about lymphatic tissue later, but those patches serve as a reservoir of immune cells and antibody-producing cells and bacteria or foreign invader fighting cells. The GI tract is very open to the atmosphere. It starts at the mouth. You can bring lots of bad things into your body through the GI tract. So it has these little signal stations all along in the Peyer's patches so that we have a place to get a first detection and a first strike capability when we detect anything going down there that shouldn't be there at all. There is another area here. The muscularis part of this system has several layers, and the reason it has the layers is for segmentation. I talked to you about the plicae circularis, which were spiral and tended to grind things up. What happens down here is a little different. As we get further along, the longitudinal muscles pull and relax the part ahead, and then two areas tend to constrict together, and they make a little sausage. Within that sausage, the grinding takes place, and it doesn't move. It sits there mixing, grinding, trying to absorb, furthering digestion. And then when the signal comes, it'll relax, move the package along. So at any one moment during digestion, which we don't get to see very much because when we operate, that all stops, we see little segments in spasm grinding up the material. You might want to become familiar with something called an ileus. Ileus is paralysis of the intestine at this point. When you open the peritoneal cavity and pick up intestines, as we do quite frequently, or move them aside and pack sponges against them, or put retractors in, or cut them, or touch them, or irritate them in any way, initially they'll squeeze down as if irritated, and then they just go blah, like that. The entire GI tract is fully capable of just going blah. And this is called paralytic ileus. You can have another kind of ileus when there's an obstruction and the dilatation becomes so great that there's no power left to squeeze. That's a different thing. We're interested in paralytic ileus because we do it to the patients all the time. As careful as we are, as gentle as we try to be, once you're working for any length of time in the abdomen, you will get a paralytic ileus for a variable period of time. You also get it from infections. You will get it from a ruptured abscess, an appendix, diverticulitis, whole range of things that irritate the peritoneum, which first starts off as spasm and then ileus. The reason this is somewhat interesting is that surgeons use this as a gauge, and any of you who've had intestinal surgery will smile and wonder why the surgeon was always asking me if I've passed any gas. The gas that you pass in your GI tract is about 10 to 20% from bacterial fermentation. The rest is all swallowed. So if you pass gas, it really strongly suggests that that air has gone from your lips all the way through the stomach, duodenum, small intestine, and finally out the rectum by an active transport, by something squeezing in a coordinated method to get it out. If you said to the patient, have you had a bowel movement today? And the patient said yes, that patient might not be ready to be fed. That patient might still have a paralytic ileus because all it takes is one contraction of the rectum to empty it. It doesn't take coordination. So after surgery, when we know the patient's, first of all, we listen, we hear quiet or absent bowel sounds, but we might hear sounds that aren't coordinated. The best test is to simply say, have you passed gas? If you have, that's usually the signal that you're going to get your first meal. Usually liquids, but whatever it might be, that's the first time something's going to pass your lips. So our interest in that is more than just physiologic and academic. Next, let's move on to the anatomy of the colon and the rectum. Again here, this is a blow-up of the colon now. We've cut off what's called the terminal ileum, the last part of the ileum, and we come to a new group of structures and names. It's approximately 5 or 6 feet long. At rest, it's about 2.5 inches in diameter from here to here. We think when the cecum blows up to about 5 inches, we are in danger of rupture. We use that number to carefully look at the cecum on x-rays if we have obstruction. And we have 4 portions of the colon. This is the first of all, the cecum is the first structure, but it's part of the ascending colon. Very simple. Transverse colon, descending colon, and then sigmoid, which means shaped like a sigma or an S, colon. And finally, that empties into the rectum. Now, there are some other structures here that are of interest. First of all, you see these, what look like little pouches all through. These are called lines of haustration, and they are where those circular muscles have been pulled tight. Also, they are where this structure comes in. See this line running along here? Well, this is the evolution of the longitudinal muscles of the rest of the GI tract. instead of it being nicely distributed around the whole circumference the way it is in the esophagus, stomach, and small bowel, it has been contracted to form 3 bands that go the whole length of the colon, and these are called the tinea coli. The tinea still contract upward and downward, and that's why they create these little wrinkles in pockets. And this is a very typical look when we're looking on x-ray and we see gas somewhere. We can see these, what are called haustrations, that tell us exactly where that gas or barium or obstruction might be. It has another minor usefulness. If you are operating to find a hot appendix, and there was a lot of pus and infection and inflammation, and you just couldn't find the appendix, you might look and follow one of the tinea, because all 3 come down the colon and meet together just where the appendix exits. So you could follow one or more of these, and you would ultimately always find the appendix. There's a mesentery that carries the vessels, and there's also a funny rotation here. If you remember going back to the GI tract, we had this long tube that began to do twisting and turning and have outpouchings from it, one of which is the appendix. However, also we had something called rotation of the gut, and the GI tract rotated similarly to the way the stomach did, if you remember that one. And this one ends up with the proximal part of the GI tract here, and then the other parts in the 4 corners of the abdomen and ending in the pelvis. There is something called the malrotation of the gut. When that happens, on occasion, this cecum and appendix fails to end up in the right lower quadrant, ends up here in the right upper quadrant in a few people, and that can fool us. I have operated on one patient who I was sure had an acute gallbladder attack, pain in the right upper quadrant, very tender to touch there, elevated white count. We operated on this patient and found a hot appendix up there because it had a malrotation that we knew nothing about. The vermiform appendix is attached at the tip. It's called vermiform because that means worm-like. Appendix means addition or add-on, which is exactly what it is. It was back in evolution an organ that is still present in many grazing animals and lower animals that use it as a side pouch for extra digestive time. Everything hasn't been digested after it comes out of the small bowel. It can go there, spend a little more time digesting in a much bigger organ. This is probably much more important in ruminants and grazing animals who eat a lot of woody and hard to digest products more than we do. So in man, it became less and less important and has shriveled up over the eons to almost nothing but a nuisance. The problem is we've gotten very good. Hardly anybody dies of appendicitis, so there's no evolutionary pressure to get rid of it now. We save those people so they can go reproduce and give their children an appendix, and they can have appendicitis. Now, as we go through this, we also name a couple of other places. There's the right hepatic flexure. Remember, hepatic referred to the liver. So this sits right under the lobe of the liver, usually touching the gallbladder. On this side, we have the left colon, or the splenic flexure, which sits and actually touches the spleen. And then the rest of it is pretty much as is named. The other question that's a little confusing in the anatomy here is that, is this an intraperitoneal or an extraperitoneal organ? Well, the answer is yes. If you look at this very carefully, the transverse colon is always, always, always intraperitoneal. However, the ascending and descending may or may not be one or the other. Theoretically, they are retroperitoneal organs. If you look at the model, what you could see and imagine is that the peritoneum could be coming off the mesentery and holding it flat against the wall on both sides. And sometimes it does. And that makes it a different proposition because in order to operate on it, you have to cut the peritoneal reflection and bring it into the peritoneal cavity, making either the right or the left side an intraperitoneal organ. Sometimes the peritoneum wraps around it and it's quite free in the peritoneal cavity. We much prefer it that way because that way it's already there to be operated upon. So the answer to that question, as I said, is yes, it can be either, and its only significance is to the surgeons and to what can happen in certain disease states. For example, back here at the cecum again, we always look at appendicitis as right lower quadrant pain and tenderness and an organ that's inflamed. This appendix is not always hanging freely like this in the peritoneal cavity. There is something called a retrocecal appendix, which is hidden behind the cecum, tucked up under the back, and is truly extraperitoneal. Now, the normal course of appendicitis is that the patient develops pain around their belly button. Pain is almost always the first symptom, not fever, not elevated white count, occasionally loss of appetite. Almost always pain comes first. Why? Because it's being stretched. The appendix is obstructed from feces or some other mechanical obstruction and is being stretched. That dermatome that we talked about, referred pain before, happens to be the same nerve that innervates the belly button. So the patient feels pain around the belly button. About 6, 8, 10 hours later, they'll tell you the pain moves down and down and down into the right lower quadrant. What's happening there is now we've got infection. The pain is no longer primarily from distension, but from infection, which is inflaming the peritoneum that covers it and runs along nerve roots that are in the right lower quadrant. And in fact, there are Eskimo tribes that use dyes in treating the patients for various kinds of pain. And they would come to a Western doctor with a blue circle around the belly button and a blue arrow pointing the right lower quadrant and then an X in the right lower quadrant. It was like a history in blue paint. And that is the classic presentation for appendicitis. Pain first, around the umbilicus, down to the right lower quadrant hours later, then elevated white count, signaling infection, sometimes low-grade fever, usually not high, and tenderness localized to the right lower quadrant. With retrocecal appendix, that all goes out the window. Any order of symptoms can occur. It may not radiate. It may, and these are the patients who get very sick and may die because we make the diagnosis so much later. Surgery's harder, but the real problem is they are much sicker when we get there, and the mortality here occurs in what we call the very old and the very young. Babies who are just crying and we can't quite find the diagnosis, and the elderly who don't have as much response to pain any longer as younger people, so they don't have pain till much, much later on. They may not have fever till much later on, so they're much, much sicker than the patient between the ages of, let's say, 6 and 60. The other areas that I'll talk to you about are of diseases that occur in the colon, generally occur more on this side, the left colon, where this is where we get most of our cancers and diseases called diverticulitis. Let me talk to you first about the blood supply to the colon, which we looked at briefly before, and I want to give you one more look. We talked about the IMA, the inferior mesenteric artery, and an interesting evolutionary event. We've developed something along here called the arcades of Drummond, named after and described by Dr. Drummond, which make it almost impossible to devascularize this side of the colon. You can cut any one of the main arteries here, 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 even as high as here, and blood can come around the other side from the SMA and fill all these collateral vessels. Blood can also come up from the rectum in the inferior rectal arteries to also supply this. This gets very important in certain diseases, for example, in something called an aneurysm, which is a dilatation of the aorta, often filled with blood clot and also atheromatous fat clot, so that the IMA has already been plugged. We would like to go in these patients and cut the aorta off here and down here somewhere and put in a Dacron graft. We would normally have to worry, but what are we going to do about the IMA? The fact is that most of these patients have lost their IMA years ago because in developing the aneurysm, they already had clot in there, and it happens slowly over many years, maybe even decades. And all that time, the collateral circulation is building up out here, so it gets its blood supply from something else rather than just the IMA, and we can just tie this off, put in the graft, and be done with it. The other thing that happens occasionally is the aneurysm may start higher or lower. The IMA wasn't involved, was open, and suddenly gets cut off, and in that case, we may have to take this off and transplant it because the colon is not used to having its blood supply cut off at that point. So the anatomy here, though rather simplistic, is really very important to how you operate. When we do operations for cancer, for example, let's say you have a cancer down here in the colon, we would like to make our cut somewhere up here, down here, and take all these vessels with us, because this is the route of spread through the lymph nodes along the vessels. In taking all of them out, we are happy to know that we have some blood supply coming from below here and from above here. So when we sew everything together, we've got a nice rich blood supply to allow things to heal. Again, extensive collateral circulation, very, very good source of extra blood supply in times of need. Let's look at the microstructure here, because it's a little different than almost everywhere else we've looked at. What you can see that's different here is that the small intestine and further up the GI tract, you have the villi. Here we have increased surface area, but they're in the form of pits, them going down with a smooth surface on top, very velvety looking. Looks just like wet velvet when you see it. Bright red, rich color, or pink from its vast blood supply. The rest looks all the same down here. But the pits are for absorbing water in this case. Remember now, nothing in the colon from the ileocecal valve on is going to absorb any nutrition. It's all water. There are no permanent plicae circulares. There are those haustral markings. The grinding, all that stuff has stopped now. And what you have left is an organ that's trying to concentrate the feces as it goes along and get rid of the water so it can be reabsorbed into the circulation and not wasted. Okay, so it starts off here very much the same composition as it was in the small bowel. Not much water has been absorbed there. Some of it has. So this is kind of a liquid-solid mix, something that came out of a blender. And as it inches its way across, by the time it gets here to around the splenic flexure, it's fairly formed and has some shape. And then it rests down here in this area as pretty much the solid, semi-solid state of a normal stool, and stays here until it's ready to move into the rectum for expulsion. The very, very bottom of this is one of the most intricate areas of anatomy in the body. This is the rectum, and we define the rectum, surgeons define it, as the place where the colon ducts beneath the peritoneum and loses its peritoneal lining. It's like the esophagus at that point. It has no visceral peritoneum or serosa. This is a very, very big blow-up, and it is guarded by the anal sphincter muscles. This is the muscle that prevents incontinence. This is what separates you again from the prey animals who are defecating all day. Predators want to defecate when it's convenient. There's an external sphincter here, which is completely voluntary. And then there is a compound internal sphincter that has lots of muscles in it of differing directions, and that is entirely involuntary. And so you have the ability to move your bowels when you want, for the most part, and when it's convenient. When you feel something called tenesmus is the feeling that something has moved down in the rectum and needs to be evacuated. This is a term, for example, that Captain Cook actually used because his crews were suffering from what he called a terrible tenesmus. They always had bowel problems on the boats. We use it more for patients who have either chronic constipation or a polyp or a cancer in there. It feels like something they can't get rid of. It's a real problem for a cancer patient that has that feeling that they have to move their bowels and they can't. Now, it may seem a little off the wall for me to be telling you about the delicate nature of this whole mechanism and how it's designed, but if you think about it, if I handed you something in your hands, which we consider one of the great instruments of all time ever evolved, most delicate, sensitive, dexterous part of our body, and I handed you a mixture of liquid, semi-solid, solids, and gas and said, hang on, don't let any of that go. You probably could for a while. Now if I said, let go of the gas and keep the solid, but don't let go of any liquid, Or let go of the liquid, keep the gas, and we'll hold the solid there. That would be a problem. It's no problem for the rectum. Rectum does that all the time. It's a very selective organ, very fine organ in what it can do. And the damage and repair to this organ is also very difficult. When we have to operate on injuries to the rectum, on tumors, whether that injury is surgical, from taking out a tumor, for example, obstetric, from a tear into the rectum during childbirth, or from infections, the preservation of these muscles is extremely important. If we lose that muscle function, we can sometimes graft muscles, but the results are far from perfect, very variable, and very difficult to achieve. So this is an area that does get infections, very high incidence of tumors, and it's a place we actually are operating fairly often. One we need to protect when we're doing surgery. And I'm going to come back now and talk to you a little bit about the surgery we do on the colon. Much different than the small bowel, which is pretty straightforward. If you need to remove a piece of small bowel, you take it out, sew the ends together, or staple them together, and they do great. This area contains stool that is about 80% bacteria by dry weight in normal conditions. So this is an area that's potentially dirty if that bacteria gets out of the colon and into the tissues of the body, especially the abdomen or your incisions. We have an organ that is prone to infection. We have something called diverticulitis. A diverticulum, plural diverticula, is an outpouching of a thin wall, kind of like a balloon, that only contains mucosa and serosa, no muscle. And it's from the high pressures. Pressure increases in this side of the rectum, and it's blown out next to where a vessel pierces, and it can contain hard, old, dried stool. That can get inflamed and light up an infection. We can also get tumors in here, which have to be operated on either electively or as an emergency. One of the things we can do is get back to resection and then use one of those ostomies I told you about earlier in the lectures. If we look at some definitions very quickly, these are words that are going to come up again and again. Tome means to cut. There are microtomes and dermatomes that cut skin. Ectomy means to cut it out. Appendectomy, you take out the appendix. Cholecystectomy, you take out the gallbladder, as you saw in the movie. Otomy means to cut it open, and it implies that you're going to close it up again. So we can do a colotomy, open the colon, take out a polyp, and close it up again right away. We can do a gastrotomy, same thing. Open it up, take out what we want, and close it. Ostomy implies permanence or semi-permanence. Tracheostomy, we open the trachea, insert an airway, let the patient breathe on that for an hour, a day, a year, and then we're going to remove it. Same thing with a colostomy as opposed to colotomy. Now we're in this situation. We have taken out this section of the colon, down near the rectum, difficult to operate. We throw this away, give it to the pathologist, and now we need to close this patient up, but it's dirty. We haven't gotten a proper bowel prep. Patient had diverticulitis, was an emergency. Something makes me worried about sewing this end to that end and getting it to heal without leaking. Be very dangerous if it leaked. I can go up to this transverse colon, which is hanging free, as you saw right there, and pull it up on a small hole in the skin, open it, sew the edges to the skin, so it's now, I've converted a colotomy to a colostomy, put a bag over it, and the feces will now come this way and out into the bag. Nothing will travel down here. If I'm really worried, I can actually cut it in half and separate the two barrels. And I can completely protect this from infection until it's completely healed. 2 weeks, 10 days, 3 months, whatever I need. Then with the patient prepped, off food, antibiotics, I can go back and close this up in a very minor operation, and that's a protecting colostomy. Very valuable tool to keep things safe. There are lots of inflammatory diseases of the bowel. Ulcerative colitis, for example, is an allergy to your own colon, always starts in the rectum and works its way back up, starts here, variable severity, and works its way back up, and always stops here if it's true ulcerative colitis. 10 years of this, you have a very high risk of cancer. These patients can be cured by removing the colon. You can remove the entire colon with no problems. patient will start absorbing water through the ileum. They live with an ileostomy. They don't like it at first, but they live normal lives. There are millions of patients out there. You probably know many you don't even realize have had it. They have normal life, normal sex life, normal job, but they have the inconvenience of having to change a bag every now and then. That's our trip from the duodenum to the anus. And next time we'll go on and look at a little bit of physiology of this portion of the gastrointestinal tract.